Hi, my name is Dr. Douglas Mack. I'm a pediatric allergist. I'm affiliated with the Department of Pediatrics at McMaster University here in Canada. I'm a principal investigator for the Thrive study and the vice president of the Canadian Society of Allergy and Clinical Immunology. I think the primary goal is to try to measure ad lib peanut consumption, and it might mean different things depending on the patients that we are seeing in this. And we have a couple of different definitions on how we're going to define that. But I think when we look at ad lib, once again, that's just like another child who is not necessarily peanut allergic, right? I think this is a child who can decide that they're going to eat peanuts one day and decide they're not going to another day. So I think what it's going to do is ideally take the pressure off both the child and the parents and allow this child to function before they're even conscious that they have a peanut allergy, really, as somebody who may not even have it anymore. And I think that that's really the goal of this, is to try to induce a change so that these patients can really function similarly to children that were never allergic to begin with. And I think that is a success that we really have seen in limited amounts in other types of immunotherapy studies, but once again, primarily in our younger children. And I think that's really why we want to target these very, very young children. Based on the other data that we've seen from the other VIASKIN peanut patches in both toddlers and the epitope and the VITESSE studies and the PEPITES and people studies, what we've seen is that the younger children tend to do better with the patch, just like in other forms of immunotherapy. But we also find that the safety signal is quite favorable in these young kids. And what we've seen in our other studies with the VIASKIN patch is that the primary side effect that we see is local patch site irritation. And it makes sense. These patients are getting a very, very small amount of peanut. In fact, they're going to get about 1/1000th of a peanut applied to their back on a daily basis. So over that 3-year period, actually, they're only going to get the equivalent of one full peanut over that entire 3-year onto the back. And that's why I expect to see this being tolerated quite nicely, because it's such a low dose. It's going to be applied to the back. There is no oral ingestion in this scenario, so we don't expect more significant safety data coming out of this. We expect to see primarily that kind of local site irritation in most of these patients. I think if Thrive does demonstrate the positive results that we expect, I think from a pediatrician's perspective, what it's going to do is prioritize how quickly we get these kids, introduced to peanut in the first place, which is what we're already doing. Early introduction appears to be best. But for those kids that fail early introduction, I envision a scenario where patients are rapidly sent to the allergist for rapid treatment right on the spot, basically. And I think that this is something that I think will change how we triage, change how we approach this, and lead to a prioritization of these kids. Because once again, if we're going to intervene, the best times I think to do this is in these infants. And so I see this real nice system where it's going to go, introduction. If they react, pediatrician's going to say, okay, we're going to send you to the allergist. The allergist is going to prioritize that, have the patient come in, patch applied, and off we go. And so I think this is something that I think is going to change how we manage peanut allergy, both now and hopefully in the future, for the better of these kids. It's going to be really, the data generated from Thrive will be critical data and the youngest peanut allergy population ever to evaluate in a clinical trial of this size with epicutaneous immunotherapy. I think it's very exciting.